The Senate Committee on Health Policy is called to order. Will the clerk please call the roll?
Chairman Hertel?
Here.
Senator Santana?
Here.
Senator Voino?
Here.
Senator Cherry?
Here.
Senator Kleinfeld?
Here.
Senator Geis? Senator Weber?
Here.
Senator Hauk?
Here.
Senator Heisinger?
Here.
Senator Runstead? Mr. Chairman, you have 9 members present. There is a quorum.
Thank you, Madam Clerk. I will now entertain a motion to adopt the May 20th, 2025 meeting minutes. So moved by Vice Chair Santana. Without objection, the minutes are adopted. I also accept the motion from Senator Weber to excuse absent members at this time. And without objection, absent members are excused. Good afternoon, everybody. We've got an overflow room too, I hear as well. Thank you all for being here today. We're going to get through some presentations, and I know we have a list of individuals who had asked to speak previous to today. We also have some folks that we received requests to speak today as well, and we're going to try to get to everybody. So I would ask the folks make their remarks as quick as possible so we can try to give as many people an opportunity to testify today as possible. We're going to have a discussion today regarding Medicaid and the cuts that we are seeing proposed at the federal level. And so first today, we have a presentation from the Michigan Department of Health and Human Services regarding Michigan's Medicaid program and how the cuts would directly impact us here in the state. We have Senior Deputy Director of Health Services, Aaron Emerson. Is Aaron here? No, that's not right though. Megan Groen. Megan, come on up. All right. I read the titles in the wrong place. So Megan is the Senior Deputy Director of Health Services and Aaron is the Chief of Staff for the Medical Service Administration. Is that correct? All right. Thank you for being with us. You can begin when you're ready.
All right, thank you so much for the invitation to be here today. We really appreciate the chair and everyone on the committee focusing on this issue that is near and dear to us as we kind of talk about what the landscape looks like at the federal level. I do want to start with, in terms of potential Medicaid cuts, those are things that are being proposed at the federal level right now in the reconciliation bill. And we'll go through what some of those specifics are in Michigan and what that would look like for the Michigan program. As of today, your Medicaid looks the same, your Medicaid card works the same, and there has been no disruption in access. And we want to make sure that people understand who is in the Medicaid program and what the impact may be if some of those cuts go all the way through. So with that, I will go very quickly through some of these background pieces, knowing that we have a packed agenda today. Just wanted to talk a little bit about the Medicaid program background. We are the largest health insurance program in the United States. We are means tested entitlement program. We have listed on here some of the different programs that we have and what that income limit is for population. So we are talking about a program for low income individuals. For children, that is a family that's under $33,000 per year. Pregnant women is just under that. And then much lower for the Healthy Michigan Plan, which is what we call Medicaid expansion in Michigan. It's just under $21,000 a year. And for traditional Medicaid, around $15,000 a year. So Michigan's Medicaid program does have a vast reach. 1 in 4 people in Michigan are covered by Medicaid. You may hear a national number around, which is 1 in 5 individuals. That is, it's much larger in Michigan. It is actually 1 in 4 of our friends, family, and neighbors count on Medicaid for well child visits, prenatal care, psychiatric visits, substance use disorder treatment, chemotherapy, and more. Wanted to share a little bit about what that looks like in terms of Medicaid enrollment by county. Many of our rural counties in Michigan have 40% of their population on Medicaid or more. That means that not only would people in rural areas lose access to healthcare under cuts being considered at the federal level, but healthcare providers in those areas who count on Medicaid to pay the bills may be forced to close. When providers close their doors, they do not just stop seeing Medicaid beneficiaries, they close their doors for everyone. Wanted to talk a little bit more about rural communities. Rural hospitals and providers are already facing closures and shortages. We see this across the country. We certainly see this in Michigan as well. We've done better at supporting rural hospitals in the state of Michigan, encouraging them to stay open since Michigan is a Medicaid expansion state. But cuts to Medicaid funding do jeopardize our ability to provide that financial support that's necessary for our rural providers. Medicaid pays for 45% of births in Michigan statewide, but that figure increases substantially in rural areas. For example, 61% of babies delivered at Munson Hospital and Cadillac are covered by Medicaid. I had the opportunity to go up to the Cadillac Hospital and look at their maternity ward and really talk with some of the staff there. And they're very concerned about what that would look like and how they cover that with 61% of babies being delivered covered by Medicaid. If a hospital does make a tough decision to close down labor and delivery, it's not just the hospital that's impacted, right? You have OBGYNs that have admitting privileges at that hospital, right? They count on that hospital for where they're going to deliver babies. And then they think, gosh, do I need to be closer to a hospital? Do I need to have that for my practice? You also have pediatricians that are then looking at, well, gosh, I need to be close to a hospital for my pediatric care. That's what it looks like for my business. And all of a sudden you look around and years down, you think, gosh, does this community still have the support that it needs to support the medical providers to have young families in that area? We also, in many of our rural areas, the local hospital is that largest employer. Wanted to talk a little bit about seniors and individuals with disabilities. And this is kind of a who's in the Medicaid program as well as a where all of the money is spent, right? So you have a small number of the individuals in Medicaid making up a majority of the cost. So seniors and individuals with disabilities make up only 15% of that Medicaid population, but it's close to 50% of the cost and the spending that we have in the program. Nursing homes receive more than $3 billion in Medicaid annually in the state of Michigan. Home and community-based service providers that support vulnerable seniors and persons with disabilities living in the community receive more than $1.5 billion in Medicaid each year. And it's hard to think of a way to come up with enough budget cuts to hit an $880 billion target at the federal level without there being any impact on where nearly half of the spending goes. Wanted to talk briefly about kids as well. 1 million Michigan kids rely on Medicaid if they break an arm, if they need glasses to read their schoolwork, or if they simply need a checkup. But Medicaid is so much more for our kids. We have decades of longitudinal data that prove that Medicaid not only improves health outcomes, but actually increases educational attainment and future wages. So you're really looking at the investment that we make in Medicaid right now for children having a financial impact and savings later. The Congressional Budget Office really looks at about half of those initial costs being offset later. Wanted to talk a little bit about Medicaid expansion, which is something that we're hearing a lot about. In Michigan, we expanded Medicaid back in 2014. When we hear people talk about kind of bringing back Medicaid to its original purpose, looking what that population is, that's generally when people are talking about rolling back Medicaid expansion. The Healthy Michigan Plan enrolls about 750,000 Michiganders at this point. It succeeded in exactly what it was intended to do. It provides health insurance to low-income people. It reduces the financial burden on hospitals who are required to serve anyone who comes through their door. It allows people to access less expensive primary care as opposed to costly emergency room visits. And it prevents people from going into bankruptcy and medical debt because someone in their family got sick. Uninsured people don't stop getting sick. They wait until they're sicker, and then they go to an emergency room. They go at a higher level of care, right, where it's more expensive to serve them, and their acuity or how sick they are is more intense at that time. So it costs more. And if they don't have money to pay that bill, it gets left unpaid. The providers then have uncompensated care, and the cost for everybody in the community goes up. Everybody who goes into that provider. So if it's a checkup, procedure, insurance, that's all going to become more expensive for everyone. It does not just impact the Medicaid population. I do want to talk a little bit about where Medicaid dollars go. Nationally, Medicaid is a major player in the healthcare system. We account for 1/5 of all healthcare spending. It's the largest payer of mental health services, long-term care services, and births. Wanted to talk briefly about hospitals. I know that we have presenters from hospitals as well, but just as a broad stroke in terms of the Medicaid program, Medicaid patients make up an average of 22% of Michigan hospitals' patient revenue. Michigan hospitals receive nearly $7 billion in Medicaid funding annually, which accounts for almost 1/5 of the state hospital's net patient revenue. The stability that Medicaid provides also supports a workforce of over 217,000 hospital employees. But Medicaid's impact is felt well beyond our hospitals. It's also healthcare providers. So we have more than 200,000 Medicaid enrolled providers across Michigan communities, delivering essential care, helping sustain the program for the 1 in 4 residents who depend on it. Listed here are just a few examples of the providers that count on Medicaid to pay for mental health care, long-term care for seniors, ambulance transport, primary care visits, and more. Talk a little bit about what that looks like for the economy in Michigan. According to the Michigan Health and Hospital Association, the state's healthcare industry is the largest private sector employer, generating $77 billion annually. A University of Michigan study found that the Medicaid expansion alone sparked the creation of more than 30,000 new jobs every year. These jobs boost the personal spending power for Michigan residents by about $2.3 billion each year and result in an additional $150 million in tax revenue annually. I wanted to talk a little bit of the challenges of reducing Medicaid spending. So how Medicaid is financed is pretty complicated, right? There's a variety of different pieces. What I think we want to make sure people know is that our match rate in Michigan is about 65%, right? And so for every dollar you're putting in, the federal government is giving us, just about $2 back, right? And so we're looking at a much higher match rate than some other states have, which is good. It also means we have a little bit more to lose here. So if we do make cuts, they will impact Michigan's bottom line a little bit bigger because of that federal match rate. You'll notice that some of our neighboring states actually have a little bit lower match rates than we do. The Michigan Medicaid budget, so looking at that and explaining that match rate, there's also different administrative matches. We get the Healthy Michigan population. We actually get a 90% match rate on that. So when you put that all together and you look at Michigan's Medicaid budget, over 70% of it is federal money. And that's something that, we really do rely on the federal government for a large portion of that. And so that's something that when we're really talking about reductions, we're talking about things that will again cost us a lot of money in terms of every dollar we put in. Medicaid is cost effective. It's a really good deal. Medicaid has lower costs than all other major healthcare programs, including Medicare and private insurance. Over the last 20 years, Michigan Medicaid spending per enrollee increased only about 18% compared to over 100% growth in health insurance premiums, national health expenditures per capita, and Medicare. Michigan also, if you look at this national map, has very low spending per enrollee compared to other states. It also means we have less room to cut. This slide shows us what the required coverage and services are. So this is, if Michigan has a Medicaid program and enters into this federal partnership, state and federal partnership, these are the services that we are required to have as a part of having a Medicaid program and being able to, again, get that 65% match rate for our program. There are also services that are optional. And so about 80% of our services were on that first slide is as required services, but we do have about 20% that spending is for optional services. The largest share is on things that you might not consider optional: pharmacy, home and community-based services. These are, again, generally for the elderly and individuals with disabilities. And so you're really looking at the rest of those columns are behavioral health, adult dental, hospice, and then a smattering of much smaller optional services that we do in the state of Michigan. When we say that spending by federally optional services is $5 billion total, I want to remind you that that's $5 billion gross, right? So if you were to take $1 out of any of those services, you're losing $3. All right. Let's go into some of the specifics of how the House Reconciliation Bill impacts the Michigan Medicaid program. We can talk a little bit about provider taxes. Provider taxes are a complicated thing. What you need to know is this is a way that the state of Michigan, and I will say 49 states have provider taxes. This is not something unique and special that we do in the state of Michigan. But what we really do is we utilize them. Medicaid tends to pay a little lower than everyone else. We pay less than Medicaid, we pay less than commercial insurance. And so for providers who need a little bit of extra boost because they cover a large number of Medicaid beneficiaries, we do give them an increased payment through provider taxes. We have provider taxes on for hospitals, for emergency services, as well as for nursing homes in the state of Michigan. The House bill changes how provider taxes are structured. They cap them. They say we can't have any new ones. They also eliminate 2 provider taxes that are longstanding in the state of Michigan. This is a little bit different than when you're talking to colleagues from other states. One of our nursing home provider taxes would be eliminated both under the reconciliation bill as well as a CMS rule that has been proposed. That is $685 million in those supplemental payments. Again, we're the largest payer for long-term care. Nursing homes count on us, and we do give them an extra boost through these. And that's something that would be eliminated under the reconciliation. We also have $525 million in state revenue that's used to offset kind of some of those general fund costs with an insurance provider assessment, as well as a state retention that we have in that nursing home piece. So that's $525 million that the state of Michigan would need to come up with. The part that's so challenging about the proposal is that they then eliminate our opportunity to change our taxes, right, and do something that would be compliant. We would be happy to change those taxes, but this bill prohibits us from doing that. It also creates a very because we have an annual approval process in the state of Michigan, that impact would be almost immediate for the state of Michigan. It does not provide a transition period or ability for us to create new or restructure taxes to come up with and offset that revenue. There are also some limits on some of our state-directed payments. A lot of the things that I think are hard here is that everything's frozen, right? The cost of healthcare goes up. It keeps going up. And what they're saying is everything that you have will either stay the same, right? And you won't have an opportunity to do that. So where the impact maybe next year versus 10 years from now is very different. Wanted to talk a little bit about eligibility provisions. I think we've probably all heard a lot of discussions about work requirements. That's something that is implemented not just in the Healthy Michigan expansion population, but would be across all of Medicaid. It requires most adult Medicaid enrollees to complete 80 hours of work per month. There are some exemptions in that for caretakers, pregnant women, medically frail individuals, but we must do that compliance at application and redetermination. The other piece that the reconciliation bill does is right now, there's an annual process. A lot of us probably have health insurance or familiar with that annual process where you have to re-up your benefits and things like that. We do that in Medicaid as well. This makes that every 6 months. I will tell you that there is a lot of churn in the Medicaid program. And so as people get that redetermination paperwork, sometimes it's challenging for them to fill it out. Sometimes they don't, right? And so we do see that churn in that Medicaid population. And so what happens is when an individual then does not have their Medicaid current, they go to a provider. It is more challenging for the provider to get paid, for the individual to be served. They can they can look at making sure they can sign up for Medicaid at that particular moment in time. But this also limits retroactive coverage from 3 months to 1 month. So sometimes somebody will go into a hospital, they won't be current on their Medicaid, but they'll be able to sign them up there. And this gives, a little bit of leeway for that provider payment to be able to go through. So it does a number of different things at the same time. One of the pieces that I think is very concerning is that people also will not be able to go over to the exchange if they are not compliant with work requirements and their Medicaid is denied. And so those individuals will be left without care. And that's not necessarily, sometimes somebody doesn't meet that requirement. Sometimes they don't submit a required piece of documentation for that. In terms of the eligibility provisions, we estimate around $155 million in implementation costs for the state, with a potential loss of coverage for 500,000 individuals. When you're really looking at that budget and coverage loss, that's something that's very concerning for us when we're spending more money and covering less people. That's not where we want to be. So that's something that's very concerning. And again, that higher churn rate and delayed care has a huge impact on beneficiaries. It also has a huge impact on providers. Those rising uninsured rates, again, uninsured people don't necessarily not get sick. They will then experience uncompensated care, usually wait longer, so it's more expensive care. And then that's something that's, again, harmful for beneficiaries as well as providers. And we're looking at that, having an impact on access to care as well as cost across the board. Just, to tie it all together, looking at those proposed federal cuts, that is hundreds of millions, at least on the front end, and potentially billions as we're looking at those freezes in provider tax. With a total general fund operating budget of $14 billion, the state really can't absorb these costs without making deep cuts across the board. And that's something that places more than a quarter of our residents' healthcare in jeopardy. And I'm happy to answer any questions you might have.
Thank you very much. I do appreciate that in-depth overview. I think it's, it's really important as we see a lot of talking points, a lot of rhetoric out of Washington, D.C. This is the direct impact it will have on people here in the state of Michigan. And when you really boil it down, and you said this directly, but you're cutting the funding coming to the state for Medicaid, you're increasing the cost for us to administer the program, and the ultimate end of that is that less people will have coverage. That will then increase costs for everybody, no matter how you get your coverage, whether it's Medicaid, private insurance, and it will hurt providers across the state of Michigan. I think it's very clear that is what will happen if these cuts are to ultimately come from the federal level. Are there any questions from committee members? Senator Geis.
Thank you, Mr. Chair, and thank you for your presentation. I was someone who does a lot of policy work around maternal health. I was really struck by the disparity between especially rural communities where there's no access to any type of prenatal or OBGYN care. And the March of Dimes recently showed that 18 counties in Michigan are in that category of being maternal care deserts. Can you share with us which 18 counties those are? And then can you also talk a bit about how that impacts the postnatal effects, not just prenatal, but postnatal, preterm birth, things that are often preventable with adequate, proper maternal care?
Absolutely. So I cannot list the 18 counties off the top of my head, but we definitely will go and follow up with that information. But we are talking about a lot of rural areas, and not limited to that either, but we've done such a good job. The legislature has done so many things in the last couple of years to really look at maternity care, right? To like both prenatal as well as postnatal. We expanded, or we, made it so that women could stay on for a full year after they have a baby, in recognition that maybe 3 months after you have a baby, you're not completely back to yourself. Maybe you still need that health care. Maybe you're not back to work. Maybe you're not all of these things, right? And to really make sure that maternity care doesn't end at month 3, right? You're still looking at an individual that needs access to behavioral health services, that may still have physical health things that they're looking at as well. We've added doula coverage. We've looked at increasing centering pregnancy and making sure that it's an available service for our Medicaid beneficiaries. When we look more broadly about some of the other things that are being discussed at the federal level, some of the home visiting programs are also in jeopardy. And that's something that, when really looking at a holistic approach to make sure women have all of the resources they need, they might not have an OBGYN right there ready for them. So how can we make sure they have the resources in their community to make sure that they're getting those doctor's visits, but also to make sure that any social determinants of health issues that they have are also being addressed so that they can be healthy, their baby can be healthy, because you really can't have a healthy baby without a healthy mom. They need that care. And so that's something we've done so much to stand that up and make sure that, by the way, it isn't going to get you to $880 billion. These aren't huge investments. There's things that we've been able to do to really make sure that our families are healthy so that we're not looking at more expensive things in the future. You're absolutely right. A lot of that is preventable.
I can just follow up.
Yes, please.
And I think you saying that more expensive things in the future, if these are preventable, then if you have access to quality OBGYNs, quality midwives, by making these drastic cuts, we're actually causing greater harm to people who need healthcare, not just immediately, but in the future, because those things that we could have prevented now no longer become long-term comorbidities potentially. So this is these types of cuts will be so drastic beyond when any of us are still here in these spaces. So thank you for your presentation.
Thank you for that important point.
Vice Chair Santana.
Thank you, Deputy Director, for your presentation. I want to touch on the work requirements because, according to the Institute for Health Policy and Innovation, 49% of Michiganders who fall into that category of are already working. And so I just want to have you kind of touch, or could you speak on how these provisions of work requirements magnify their potential coverage losses in the state?
Yeah, so I think, it's an interesting thing. We don't have an exact number of how many people are working. I suspect it's probably I think it's most. And we have done some studies right when Medicaid expansion happened about, how many individuals are working. And we do believe that it's most. Adding a requirement that, it will require a lot of communication with individuals, right, about how they then comply with that work requirement. It's also they needed to be working the month before they applied. And so it might be a little bit confusing for an individual who's like, great, I just got a job, I'll apply for Medicaid. And then to get that determination letter that they in fact did not meet the requirements is going to be very confusing for individuals who are just reaching out, getting a job, trying to make sure that they have health care for themselves and their family. And so we are very concerned about both what that compliance looks like for individuals who are working and individuals who are not, for a variety of reasons. We actually saw when we expanded Medicaid in the state of Michigan, we did have a lot of beneficiaries that said, hey, I actually got healthier. I actually started work, and we actually saw it work in that direction because their healthcare costs or their healthcare needs were met, and maybe some costs that they had that they were trying to cover on the side allowed them, to again access that care and actually start working.
Yeah, it's very important. I was in northern Michigan not too long ago reading a news article about a man who fell off. He was doing some work for an individual at their home, and ended up hurting his hand and went to the hospital and was able to apply then and there with some services and support from Medicaid and get the services that he needed right away. It just seems like we're putting a lot of red tape around something that's beneficial to a lot of Michiganders in our state.
Absolutely. Thank you.
Senator Kleinfeld.
I saw on watching the news the other day, one of the senators up there in Washington make a comment to the effect that if you want to solve this problem, the answer is get a job. Which the insinuation there is that healthcare is only something that it is up to a company to decide whether or not to afford upon somebody, as opposed to being a basic right and necessity that each and every American has. Thank you. That was just a statement I wanted to make, but with respect to the rural areas, these can grow if more rural hospitals have to close that are near the counties that already have. Individuals have to travel further and further, and it can become an untenable situation where you really can't get access. I'll tell you where my parents live. It's in another state, but they have to drive an hour and a half to get to go to most of the doctors that they see. So that can grow, and along with it is a further exodus from the rural areas of people that were employed through the hospital, like doctors. And isn't it true that if the hospital leaves and the doctors and the nurses leave, that they're not real easy to get back?
That is my understanding, and certainly I think what there might be others that are testifying that can speak to that with more authority, but that is my understanding. And I don't know, when we're asked to stand things up, right, and how can we increase access in a community, it's very challenging if those resources don't exist. It's easier to add on, right, and support additions. It's very hard if we don't have doctors in areas, if we don't have like the nurses need the doctor, like it all goes together. And so those job losses are pretty huge.
So the closure of a facility is more difficult to open it back up because you don't have the infrastructure around it to open it back up.
Yeah.
I am concerned about that domino effect of more and more rural hospitals closing, because my understanding is that they're struggling to make ends meet as it is. I think it could become a national crisis, especially across the heartland. So thank you. That's all I have. Thank you.
Senator Geis.
Thank you. Senator Kleinfeld's question about the closure of facilities. Can you talk about that impact on FQHCs, federally qualified health centers? Because many of those patients are also Medicaid patients, correct?
Absolutely. I think most FQHC patients are definitely paid by Medicaid. I do think we have an FQHC who's ready to testify as well too. But what I can definitely tell you is that kind of those safety net health centers receive about $483 million from Medicaid each year. And that accounts for about 63% of their patient services related revenue. So those are some specific numbers from the Medicaid program in general. But as you talk to individual providers, that might look different in different communities. I will say I had an opportunity to talk with some of the tribes as well about what this looked like for some of their health centers. And it was north of 80% of their individuals were paid for out of Medicaid. And they did not serve just they serve a broader amount of the community as well. So I think the impact on those safety net providers really is an important thing to discuss.
So it's not just the hospitals, which I think when people think of like facilities that are closing, they think, oh, it's the hospital. And we know of hospital systems where they've shut the doors or because of merging or whatever, but it's also places where people go for their childhood vaccinations and those well-child visits and making sure, finding out if they have strep or not, the very routine things that are more about wellness and being healthy as opposed to curing illness.
Absolutely. And the places that we probably want people to be so that they don't end up in an emergency room.
Thank you very much for being here and for the presentation. We really appreciate it. And if folks have any other questions, we can follow up afterwards. Thank you.
Great. Thank you so much.
Next, I will invite up Adam Carlson, the Senior Vice President of Advocacy for the Michigan Health and Hospital Association, and with him, Jeremiah Hodshire, who is the President and CEO of Hillsdale Hospital. Thank you very much for being here today, and please begin when you're ready.
Thank you, Mr. Chair, members of the committee. Thanks for inviting myself and my hospital colleague here from Hillsdale. My name is Adam Carlson, Senior Vice President of Advocacy for the Michigan Health and Hospital Association. The MHA represents all 129 acute care hospitals in the state. Those are the hospitals that are open 24/7, 365 to care for the patients in your communities, regardless of insurance type or ability to pay. The ones caring for your loved ones, your neighbors, your friends, and community members. According to the Congressional Budget Office, the reconciliation package passed by the U.S. House will lead to more than 10.9 million people losing their health insurance coverage. The department did a great job outlining the other financial ramifications to the state, but I think we can all agree that this bill goes beyond anyone's reasonable definition of waste, fraud, and abuse. These changes will lead to real impacts on patients as well as hospitals and providers. And I appreciated the comments on birthing services because Medicaid is the single largest payer for maternity care in the state of Michigan. And when a hospital has to make a difficult decision to no longer be able to offer birthing services because of potential cuts, that impacts everyone in a community, not just those who access their health insurance through Medicaid. With that, I want to turn this over to JJ Hodshire to share a little bit more about the local impact on Hillsdale specifically.
Appreciate the opportunity to be here, Chairman Hertel and committee members. Thank you for allowing me the opportunity to address the committee today on the uncertainty of Medicaid and the program's sustainability. I am Jeremiah Hodshire, President and Chief Executive Officer of Hillsdale Hospital, where I've served for the past 15 years. I'd like to give a brief overview of our hospital and where we're positioned today. We're an independent, non-for-profit hospital, and we have been in operation for over 109 years. It was started by Doctors T.J. Midgley and his wife, an RN, who came to Hillsdale with a passion and a vision for creating a healthcare system in which community members could receive care. Since its inception, all of our acute care hospitals provided exceptional service to those in need in our community, irrespective of their ability to pay. We have transitioned from a very small, simple payer system back in the day of bringing in canned goods to pay for services to a very complex payer system right now in our rural communities. Like mine, our community finds a gap, and that gap is fulfilled in the much needed Medicaid program and the coverage to payments of hospitals just like mine and to providers just like ours. Now, you could only expect that in 109 years, we have survived many challenges in our facility. We've had fires, we've had floods, tornadoes, stock market crashes, the pandemic, and yet each time our team comes together to ensure that we can move forward stronger and ready to face the new challenges of serving a population which is mostly comprised of rural and poor community members. In fact, roughly 70% of my payer mix is the government, Medicaid and Medicare programs respectively. Now, I testify before you this afternoon with a sense of urgency and with a petition for us to lift our voices collectively to ensure that these deep and dangerous cuts to patients, hospitals, providers, and communities is minimized. Our hospital story is no different than communities across this nation. The loss of healthcare services and hospital closures is not just impacting Medicaid patients. When the hospital closes, it impacts all patients. Commercial insurance, Medicaid, no insured, everyone suffers. Today, I want to highlight the faces of Medicaid. We have launched a series of personal testimonials demonstrating the positive healthcare outcomes associated with those who receive Medicaid and who have been unable to cope. Perhaps it was a mental illness. Perhaps it was a chronic illness. Children, homebound seniors, chronic illnesses, and everything in between. This program saves lives every day, right here in Michigan, in our communities. Whatever it is, we are serving the gap in our respective communities. Now, We can often reflect upon a word that was used in a presidential campaign back in the 1970s. We can refer to that as the Ronald Reagan quote, description of welfare queens, collecting state benefits, providing for and obtaining free money and benefits without a contribution. However, the faces today are those we have in our own family, those we go to church with. It's our farmers, our grocery store clerks, it's our pastors, and it's the neighbors we see in our community every day that we're involved. Let's not forget the seniors who rely on Medicaid as a supplement to their Medicare program, and prescriptions that are affordable. Office visits are manageable, and they can get the health care that they need. It is a safety net healthcare program that aided me and my family of 7 growing up in rural Hillsdale County, the very program that now finds itself in the crosshairs. One community member who relies on Medicaid to ensure her sister is living comfortably and receiving the care that she needs in an assisted living home made a very poignant statement. She lamented it shouldn't be a Republican thing or a Democrat thing to care about each other. It should just be part of humanity. According to the Nonpartisan Congressional Budget Office, early estimates that there's approximately 10.3 million people that could lose their Medicaid coverage if this bill becomes law. This is not fear-mongering or peddling inaccurate information. This is what budget and policy experts in Washington, D.C., and beyond are saying will be the impact of this legislation. This is why we are concerned today. Notwithstanding the medical devastation and the deprivation and care deserts and the lack of access to care, local economies across the country, and specifically here in Michigan, will be devastated. Our community hospitals typically represent the largest employer base in the regions. For example, Hillsdale Hospital, 2nd largest in the city of Hillsdale, 3rd largest in the county of Hillsdale. Our national podcast, Rural Health Today, we hear the exact same story from Texas to Nevada about how they're serving their local communities, how they're bolstering the local economy, how they employ hundreds of people who buy their cars and their groceries locally and build talent pipelines to support our community's future. Let's not forget the collective millions of dollars contributed back by means of community benefit from these hospitals. We help supply our food pantries, support countywide economic development, bolster community events, host blood drives, vaccine clinics, and the list goes on and on. To say that hospitals and providers are gaming the system is a direct insult and an inaccurate and dishonest representation of what we are truly doing and attempting to achieve. During numerous press conferences and congressional hearings, we continue to hear that the $880 billion reduction to the Energy and Commerce Committee budget will target fraud and abuse and somehow create a stronger America. During the same period, we have heard President Trump say, don't touch Medicaid. And as such, I'll stand firm with President Trump on that. Don't touch Medicaid. On the surface, this sounds very noble, valiant, and almost a defense of healthcare for those who need it the most. However, underneath the surface, what is not being discussed is negatively impacting hospitals like ours. It's in the proposed cuts in this legislation, as Medicaid has definitely been touched. Let's not forget that the new statewide polling conducted by Epic MRA demonstrated that 82% of Michigan residents oppose cutting Medicaid. They oppose it. Nationally, an ICYMI poll revealed that 70% of voters oppose Medicaid cuts. Where fraud, waste, and abuse exist, I think we all can agree that we need to deploy the extent and the full extent of law, including criminal or civil penalties, to address those offenders that are violating any type of law. But we cannot do this on the backs of those who need coverage the most. However, even this notion of fraud and abuse doesn't equal a fraction of a percentage of the $880 billion in cuts, and does not represent the overall will of the voter and the people in this state and in this country. Now, regarding the stereotype of a 27-year-old male sitting in his parents' basement playing video games, I want to let you know that we work very closely with Medicaid program specialists at our hospital. And we have found that when we refer individuals to seek coverage, access to healthcare is not simple and just guaranteed. Strict scrutiny over individual finances, property, assets, and subsequent verification, as well as any documentation of previous coverage, is explored before any coverage is granted, based on my experience right here in this community. Scaling back on the retroactive Medicaid payments for 3 months to 1 month for skilled nursing facilities will in fact keep many patients from obtaining much needed long-term care. Where we see these non-insured individual and patients show up, where will that be? If their primary care provider does not accept or no pay or as a form of payment, what will happen? These patients will show up in our emergency departments across the state of Michigan and across this country. We are required by EMTALA, a law, to treat every patient, and therefore cannot under any circumstance deny patients based on their inability to pay, inability of their citizenship status. So here's yet another uncompensated care at the highest cost point in healthcare, and it will shift to the individual hospitals as bad debt. It becomes my problem now. Already struggling hospitals, many with no margins, cannot sustain these major cuts that will occur as a result of this program. What types of programs would hospitals end up cutting? Obstetrics, psychiatric care, and the list goes on and on. These are core services that support the most needed services in our community. The Chartis Center for Rural Health identified that 182 rural hospitals in the United States have closed or stopped providing inpatient services since 2010. Further analysis by Chartis revealed that 46% of rural hospitals in the United States are operating in the red. 46% of us. And 432 are vulnerable to closing prior to this legislation. This is the landscape today, prior to this devastation. In this year alone, as of May 2025, 16 hospital closures and emergency department closures have already occurred. Understand one thing, this legislation will accelerate hospital closures. With the recent analysis that 20 Michigan rural hospitals are at risk of closing, and 6 of those are at immediate risk of closure. Now, some might welcome this as big systems can do a takeover or forced sales or mergers and big for-profit systems that can come in, but understand they will not receive the care that they need. Overtaxed ambulance companies who operate on shoestring budgets and reduced reimbursements will be overwhelmed with long-distance transports eating up the local resources reserved for emergencies. Receiving hospitals will be over capacity, and patients will board emergency departments for days, if not weeks, waiting for admission. The entire system will come to a grinding halt, and over time, the economic fiber of these communities, like mine, will be disintegrated. What is at stake here is that with the declining commitment and enrollments, reduced payment models to providers, and revocation of much needed programs, divesting of these services will be what shutters the doors of our hospitals. This is not sustainable. We cannot do this. We cannot get paid less than the cost of delivering the service that we're delivering. We're not talking today about nurse wages and the difficulty of nurse recruitment or physician deserts and areas and communities where we can't even recruit primary care physicians to come into the community. This will only be intensified by this type of legislation. So what happens next? I say we must find solutions without delivering these cuts on the backs of our patients, and more specifically, on the backs of struggling healthcare systems and independent provider practices who will be forced to shutter their services. I do not believe also that Michigan can sustain a $1 billion shift from the federal Medicaid program to fund Medicaid at its current level in the state of Michigan. In order to cover even a fraction of this, states like ours will either be forced to increase individual or business taxes, that's not popular, or will be forced to deny access and assistance to local community hospitals like mine and health systems. And it is here at this moment where we will witness the biggest impact on the health and wellness of our communities. They will deteriorate. I appreciate the opportunity to be here today to present our story, and I look forward to any comments or questions that you may have for me. Thank you.
Thank you very much. I appreciate your candid comments and talking about the direct impact that this will have. And what is the most disgusting thing to me is the fact that all of those impacts that you just talked about in your community and that will happen across the state are being made simply to give a large tax break to some of the richest people in this country. And, you know, over the last few weeks, we've talked a lot about Medicaid in my district as we've seen this bill introduced and the potential impacts, and have heard directly from people that are afraid that their coverage will be impacted. And I've been told by so many people on social media that it's all bluster and it's nonsense and that it's not real and that it's just fear-mongering, is what you alluded to. These aren't Democrats or Republicans that are talking to me about their fears. They're people that are worried about how this will impact them and their ability to access care. And there is no doubt that everything you just said is true in so many communities across this state if these cuts are to happen. In fact, as recently as overnight, the President of the United States in a social media post said that this bill does not have any cuts in it. And so it's either ignorance or a lie. And either one is wrong. And so I appreciate you sharing the direct impact. This is a really important conversation for us all to have. Vice Chair Santana.
Thank you, Senator Hertel.
Thank you so much for your candidness. When you look at the state of Michigan, we have an aging population.
We do.
Within the next 5 to 10 years, we will have baby boomers who are beginning to retire, and their healthcare needs are going to be impacted significantly, which means that we as a state need to consider how we are delivering of care. And so can you just talk a little bit about how that would impact your hospital specifically with that aging population, and kind of elaborate on how the compounding challenges will occur for your specific hospital?
Thank you, Senator. I appreciate the question. So if you were to look at our community needs assessment, you would find that the growing population, unfortunately, in my community is 65 or older. It's not always necessarily what you want to see in a community, but it is what we're faced with in that reality. We're also faced with the fact that because of the nature of our economy, and the poverty levels, that many in that population have dual coverage, which is both Medicaid and Medicare. And that is a very important aspect because it does give them access to healthcare needs and services. Among those, if you do not know, but Medicare does not cover certain things such as dental and other options that are available, vision and hearing, for example. And the Medicaid program does cover those. So it does give access to those services. Access to specialty care, primary care, all of those things are so critical. But you know what's at stake here is if our community hospital has to close, access to care is denied. It doesn't even, we won't even talk about specialty care. We're going to talk about individuals who have to travel 45 minutes or an hour to the next healthcare facility. The issue with that is in rural communities like ours, there's no public transportation. The difficulties, families and support systems, it makes it very difficult. The other area of concern in that population is long-term care. We operate a 38-bed long-term care facility, and we have to retroactive a lot of those expenses once an individual is accepted for admission. And now going from 3 months to 1 month is going to be a significant challenge. It's going to deny some care. That's also a concern for us. And then looking at just the impact of post-discharge. After a patient is released from the hospital or medical care facility, they go to home care. It's another service in which we're heavily Medicaid dependent. Again, 70% of my payer mix, the government. And so when you strip down any of those dollars with no margin, it now means shuttering the services that are most important to the most vulnerable in our community, like the seniors.
Senator Geis.
Sorry, I just want to clarify the good senator's comments. Folks always forget Gen X. It's Gen Xers who'll be retiring in the next decade.
Thank you, Senator. Thank you very much for your testimony. We really appreciate it. Seeing no further questions.
Thank you, Senator.
We will now move on to testimony from Monique Stanton, who is the President and CEO of the Michigan League for Public Policy. Thank you for being here, Monique. Please feel free to begin when you're ready.
Good afternoon, Chair Hertel and members of the Senate Health Policy Committee. My name is Monique Stanton, and I'm the President and CEO at the Michigan League for Public Policy. A copy of our full testimony has been shared with you. I won't be going over all of it today. I am honored to be here today representing Protect My Care, the coalition to protect Medicaid in Michigan. We represent over 260 organizations throughout our entire state. Members include healthcare clinics, hospitals, advocates, businesses, labor, faith-based organizations, senior serving groups, and more, representing thousands of lives and Michiganders in every part of our state, from rural communities to cities to suburban neighborhoods. Medicaid is foundational to our healthcare delivery system in Michigan. 2.6 million people in our state have healthcare insurance because of it. 45% of our births are covered by Medicaid. It's the largest payer of behavioral health services. It's the largest payer of long-term services and supports, including things like nursing home care. In 41 counties, 37 of which are rural, over 20% of those residents rely on Medicaid to get their healthcare coverage. Medicaid is critical to our economy and has a $4.9 billion economic impact in our state. Steep cuts could result into up to $2.9 billion in a drop of our state GDP. Medicaid is also widely supported by people. Results from a recent poll show that 83% of Michiganders want to see Medicaid spending increased or kept about the same in our state. 86% of Michigan residents feel Medicaid is important for people in their local community. Slashing it is not going to reduce our healthcare costs. We've seen lots of points about that today. And proposed changes mean that we're going to have to make really difficult decisions in our state. And ultimately, individuals and families will need to make difficult decisions about paying their bills or accessing healthcare. When we talk about numbers in the millions and billions, it's really easy to lose sight of the impact these cuts will have on real people and real communities. I've shortened our testimony today verbally so you can really hear from the impact on communities across Michigan and what they will mean to people's lives and their areas. So I'm happy to answer any questions or turn my time over to some of the other speakers that are here today.
Thank you very much for your testimony. Any questions from committee members? We're going to let you off the hook.
Okay.
Thank you. Next, I will ask George Olson, President and CEO of the Sterling Area Health Center. Please come forward. Thank you, George, and please begin when you're ready.
Well, good afternoon. Thank you for this opportunity to speak in front of you. I am George Olson. I am President and CEO of Sterling Area Health Center. We are a federally qualified health center. Our catchment area is Northern Bay, Aranac, Eastern Gladwin, Ogama, and Iosco County. I also am our organization is a proud member of the Michigan Primary Care Association. I know you guys have heard a lot of numbers today, but I do want to give the impact of both the Michigan Primary Care Association, which is made up of community health centers, most of which are federally qualified health centers, as well as we represent Indian community health services as well. Today, 51% of our patients are on Medicaid. 10% are uninsured. 15% are on Medicare, and roughly just under 25% are privately insured. Of our patients, over 13,000 are veterans. Just under 260,000 live in poverty. 200,000 of those patients are children, and 36,000 of those patients are homeless. Federally qualified health centers employ almost 6,500 people in the state of Michigan. Our practices help save the Medicaid program $612 per encounter per patient visit. We save the Michigan Medicaid program about $171 million a year. We do over 2.5 million patient encounters per year. I would like to say an analogy is that federally qualified health centers and organizations like mine, for decades, we have stretched the dollars as far as they can possibly be stretched. There is no more stretching. Sterling Area Health Center, as I said, we have managed to grow under my stewardship and leadership and a lot of hard work of a lot of great people in our community. When I joined the organization a little over 6 years ago, we were 5 clinics, 1 dentist clinic, 4 primary care locations. Here just yesterday, we opened up 2 more school-based clinics, and by the end of this year, we'll be at 10 clinics in total, which is a great accomplishment. But I do have another story to tell. Unfortunately, in November of this year, as we've stretched dollars, and they do not stretch any further than what we already have, in our current reimbursement climate, I had to reduce my work staff by 10%. About 125 employees, we brought that down 10% in November. Really no choice in the matter in regards to how we're currently reimbursed, our current payer rates. I would also say a topic for another conversation, but private insurers and other insurance companies, the delays in payment and the barriers in which that they put in payment have affected us negatively as well. As you may know, federally qualified health centers are funded by what's called an H-80 or a 330 grant. That requires us to be a safety net organization. That 10% uninsured is required. Much like the gentleman spoke earlier from the hospital, we are required, regardless of your ability to pay, to see you. We welcome that with open arms. That is our mission. That is what we do. But any major cuts to Medicaid that are obviously in our future, that number is going to directly proportionately grow. The uninsured is going to directly proportionately grow in regards to those that come off the Medicaid program. With that, I just talked to you about a 10% cut in November in our current situation. I will also share, and although this is very public, I'm actually in current discussions with my board of directors tomorrow in reducing services further in one of my clinics that is the most rural. And they spent over 2.5 years to recruit a physician that's been there less than a year. And I may have to take that from full-time services to part-time services or less. Our community can't absorb that. Our organization cannot continue to absorb a larger amount of uninsured. I will also say I've had very direct conversations with our Washington elected officials in regards to our H-80 or our 330 grant, in regards to if you're going to reform Medicaid at this level and you're going to put the burden on the federally qualified or the community health centers or the hospitals, what are you doing to their grant? And the answer is nothing. We're going to do nothing. I can't speak to the zeal there, but I will tell you personally, my eldest son is on Medicaid and on a Social Security stipend. He's non-employable. His mother and I help subsidize rent, utilities, and things like that. We also help for other things that Medicaid doesn't cover that he needs for his well-being. I'm fortunate my oldest son has us because most folks don't. I worry about my community. I worry about every federally qualified health center. There are over 40 of them in this great state of Michigan. All of them have been looking at cuts. All of them have been trying to forecast what's coming. I will tell you, even a 10 or 20% increase in the uninsured to Sterling Area Health Center will lead to more cuts. And instead of looking at one health center or one location going part-time, it will close and others behind it. I thank you. I don't have answers today. All I can do is give you the information of what I have and give an impassioned plea. Let's find a way. And I will guarantee you the Michigan Primary Care Association and the leadership of every FQHC in this state will stand shoulder to shoulder to come up with solutions.
But your information that you're providing the committee and your experience is incredibly important because I think these are the stories we need to hear. And federally qualified health centers have done an amazing job at giving access to preventative care for people all across our state. And we all know, I think, sitting here today, that the biggest way to reduce healthcare costs is to provide better access to preventative healthcare. And so that requires providing people access and giving them the ability to access that care, not taking it away, which is what is happening in this bill at the federal level right now. And so your ability to share with us how any more cuts will impact not only your organization, but the care you're providing to so many people that's really what we're trying to get to today. So thank you very much. Any
If I can
questions?
add, sir.
Yes.
And I'm sorry, I should have mentioned, I was trying to remember everything and I have great notes in front of me. But these fine folks were talking about the desert that's happening with providers. One of our local hospitals just announced that in July, they are shuttering their OB program. I don't want to name the hospital. It's not my place to do so. But this and services and hospitals have recently been acquired. And, you know, it's been touted as expansion of services and that things won't happen. One of these hospitals is that hospital that just got acquired and the community was promised no reduction in services. But it's not sustainable. I spoke to one of their leaders just earlier this week, and they talked about that just that department, they lost $1.2 million. And that's in today's environment. And that's with the things that are already out there in place in regards to helping these hospitals and health centers be able to function the way they are today. Thank you.
Thank you. I sit on a national fellowship examining maternal and infant health, and I know Senator Geis has done a lot of work in that area as well. And it's 45% of the births. It's very simple. 45% of the births in Michigan are covered by Medicaid. It is the biggest loser of funds in a hospital, in any hospital, not just here in Michigan, across the country. And so that's the first thing to go when you see things get cut and tough decisions have to get made. What that means, though, is people have to drive an hour or 2 hours in order to access good care. I was born 7 weeks early. My lungs collapsed when I was born. If I was born in an independent birthing center, not with access to a NICU, I wouldn't be here today. My oldest son was born with an emergency C-section. If we were not in a hospital with a NICU, he might not be here today. And those stories can be told so many times. And so it is detrimental to the health of communities when those facilities close. Any other questions from committee? Senator Chair.
Yeah, thank you for the testimony. And I guess it's not so much a question, but just to underline, right, when you're closing a location, everybody is losing access to 100% of the population that was using that location or whether it's using the OBGYN services, everybody loses access. And, concur with my colleague here, healthcare is not welfare, right? But we need to understand, we're not just talking about folks who are on Medicaid or uninsured who are going to be impacted. It's everyone who relies on the availability of those services. Thank you.
If I can add to the statement, in the area where the clinic is that I'm looking at having to reduce services, in an acquisition of a health center chain in that region, they just shuttered the primary care clinics that were in the same small town. And so again, this is a disaster that's happening. It's only going to get worse with these cuts.
Senator Geis.
Thank you so much for your testimony. I really appreciate it. I think it's also important for us to realize, we are the Health Policy Committee, but when you think about, none of these things are in silos, and we're talking about how it's going to affect the job cuts to the community, other people who are not on Medicaid, not having access to care. But when we also think about those impacts of what if people don't have transportation and they're delaying care further, we know the percentage of kids in the state who have asthma, for example, and how that impacts the, not having access to your albuterol inhaler, how that's going to impact school and academics. And so all of these things that were health and wellness and being able to have that access impact other areas. I don't think we can lose sight of that because it's not just about physical and mental health. It's also, and we can also talk about the decline of mental health when you are unwell. That's a whole other aspect of all of this. But making sure that we're very intentional about seeing this Venn diagram of all of these areas.
Thank you very much, Senator. Thank you for your testimony. I appreciate you being here today.
Thank you.
Next, I'll invite up Katie O'Neill, a private citizen whose family relies on Medicaid to cover their child's surgeries. Katie, thank you for being here with us today, and please begin when you're ready.
Good afternoon. My name is Katie O'Neill. I'm a school nurse in Ypsilanti and a mom to 4 children. My son, Nathan, I brought a picture of him for you. He is 6 years old. He came to our family through the foster care system. He was born 11 weeks premature, and because he was in foster care, he was placed on Medicaid immediately. He came home to us around 7 weeks after he was born. He was tiny and fragile, and luckily at the time he was healthy. Within a month of his arrival, this was no longer the case. Nathan became very congested and wasn't eating, so I took him to the hospital. At the time, I didn't worry about who would pay for it or how much it cost because he had Medicaid. In the emergency room, he was diagnosed with RSV, intubated, and admitted to the ICU. We lived there for the next 2 months. As he recovered from the illness, it was clear he could not breathe well on his own. We discovered he had subglottic stenosis, which is a narrowing of his lower airway. Doctors performed a tracheostomy, putting in a plastic tube right in his neck. And they informed us that if Nathan pulled out his trach, he could die. If it got caught on something and came out while he was crawling around our home, he could die. And if it got clogged up, he could die. So anytime I was not with him, a home nurse with a high level of skill and education had to be with him. All of this required a truck full of medical equipment, and Medicaid covered everything. 3 years later, Nathan's surgeons decided that the only way to reverse his tracheostomy was to reconstruct his airway. They cut out the narrowed piece of his trachea and sewed the 2 ends together. We were in the ICU for 2 weeks. Because he was nearly adopted at the time, I was able to see through his patient portal for the first time how much it cost. The final bill was over $100,000 for our 2-week stay. I couldn't even imagine how much his 2-month stay had been when he was an infant. After his reconstruction, Nathan was in and out of the hospital every few weeks for follow-up evaluations. Medicaid covered it. We celebrated birthdays, we finalized his adoption, and he got a new baby sister. Nathan spent hours doing things he loves, mowing the lawn, scooping snow off our driveway, and playing baseball in the yard with his brothers. We were able to send him to school. He finishes kindergarten this week. I could never have imagined his life being so stable. Through Medicaid, we were able to get additional supports to help him be a normal kid. And because of Medicaid, my child, who could not speak a word until after he turned 3, can talk and tell jokes and yell at his little sister. Most people don't know he ever had any medical issues, but late last summer, he started making strange noises when he was breathing. And in February, we went into the hospital to investigate. His surgeon found that his upper airway, the supraglottis above the vocal cords, was narrowing and collapsing on itself, a very rare side effect of a tracheostomy repair. Nathan has had 4 procedures since then, and another one I just scheduled yesterday to try and fix this problem. And instead of fighting with an insurance company, I've been able to focus on my kid because Medicaid was there for us. We are now faced with another reconstruction later this summer. I have anxiety about the outcome and his life after surgery. I worry how first grade will go, and I wonder if we will ever escape this cycle of airway procedures. But I don't have to worry about convincing my insurance company that it's necessary. Medicaid has been there for us at every turn, and now there's a public debate about whether families like mine should still have this kind of support. With Medicaid, I get to be Nathan's mom. I get to watch him chase his little sister around our yard and dig in the dirt pile out back. I get to take him on bike rides and go to the splash pad. I don't think about insurance claims because Medicaid has him covered. I get to listen to him read me chapter books because Medicaid taught him how to speak. I get to laugh with him about how hard subtraction is because Medicaid taught him how to learn. He is adamant that addition is easier. My son is enjoying a normal childhood because Medicaid made it possible. Being a parent is really hard. Being a parent to a medically complex child is significantly harder. I have friends whose kids aren't covered by Medicaid and they spend hours on the phone trying to get their bills paid or procedures covered for their children. If Nathan weren't covered by Medicaid, I would also be in that boat. And I cannot imagine a world where me and Nathan do not have either option available. Budgets aren't just about allocating money. They're a statement of priority. Funding Medicaid tells families like mine that our kids' childhoods matter. I know you have a lot of tough decisions to make during budget season, but if Medicaid gets cut, those tough decisions fall on families like mine. As you make these decisions and talk to your counterparts in Washington, please don't leave Nathan and 970,000 other kids in Michigan behind.
Thank you very much for sharing your story with us. Any questions from committee members? Seeing none. Thank you very much, and we wish the best for Nathan as well. Thank you. Next, I will call up Courtney Gilmore from Grand Rapids. Courtney, please feel free to begin when you are ready. Thank you for being here today.
Hi, my name is Courtney Gilmore, and as you said, I'm from Grand Rapids, Michigan. My story is going to echo some similarities to Katie and tie in some things that you've already heard today. My son, Andrew, is 6.5. When he was born, we lived in Manistee County. We had a healthy full-term pregnancy. We were in rural Michigan. There were no high risks to think I needed to be anywhere else. But when he was born, his cord got pinched and he lost oxygen for an unknown amount of time in the last 10 minutes of labor. It was too late to do an emergency C-section, so he ended up with brain damage due to a loss of oxygen during labor. So when he was born, he was sent to our local ER that was not equipped to deal with that. He was put on a helicopter to Helen DeVos. I had to wait for services to take care of me and then later be driven down by my own family to the NICU to meet up with him, where we then lived for about 30 days before getting to go home again. And we have relied on a variety of forms of Medicaid in his 6.5 years of life so far, learning along the way. It is not an easy system to navigate. My husband and I are both educated and had careers. We were a 2-income household and we are a 1-income household so that I can be Andrew's mom and advocate and take care of all of his medical needs and everything else along the way. The first thing we encountered was children's special health care that is available to our son because of a specific diagnosis. So on children's special health care, if you have a specific diagnosis for your child, then specialist medications visits are covered related to that diagnosis only. That helped us get through our NICU stay. It helped us get through the first few years. When Andrew was around 4 years old, things were getting harder. He was having pneumonia. We were having hospital stays. It was affecting every area of life. And we learned about the Children's Waiver Program. So the Children's Waiver Program is kind of a step up of coverage from children's special health care. And it was an extensive, complicated application. It was invasive into questions into our life, everything about our whole family, even though we were just trying to get coverage for our one child. And they don't make it easy. So it's extremely frustrating to me when we hear things like waste and fraud. I cannot imagine scamming the system that is currently in place. I have a master's degree and it's hard enough to get my kid the care that he very much qualifies for. We have had private insurance throughout this whole thing, and I think a lot of people don't understand that private insurance does not cover everything. There are a lot of things it doesn't cover. We had, and my husband still has, a good corporate job with good insurance. But there's so many gaps that fills. Just a few examples. There was a medication my son needed. The medication was covered, but because he has a G-tube, it needed to be compounded into a liquid that could go through his G-tube. And our insurance wouldn't cover the compounding of the medication. They would cover the drug itself, but not to have it made into a form that he could take. Medicaid could fill that gap, help get him that last little bit of the cost that Blue Cross didn't cover. As he's gotten bigger, a wheelchair van, Blue Cross, and a lot of things with Medicaid, you have to get denied. You have to apply for grants. You have to apply for other forms of services and help before they'll cover it. So you are using other resources first. And for his wheelchair van, for him to travel safely to his appointments, I needed to reach out to Blue Cross to get it denied, even though I know it's not covered in their policy. And I was told on the phone that that's a caregiver convenience. It's for my benefit for him to be able to go somewhere else. Now, I knew they would deny it, but I didn't expect to be told that. Medicaid, the Children's Waiver Program, helps cover the modifications to the vehicle. We still have to buy the vehicle, have the vehicle for our family. These aren't handouts. It's a safety net. We have one vehicle for our family. We don't have a TV. We don't have gaming systems. Someone else mentioned the stereotype of, living off of a system. We work hard. We're still employed. We're still have private insurance to help, but Medicaid has been so necessary to cover the gaps in our son's care. He has quad cerebral palsy, he has epilepsy, and relies on a feeding tube because the brain injury affected his muscles in a way that he can't safely swallow. And I need to be home with him, and Medicaid has allowed me to do that and for him to safely be at home with our family where he belongs. Quality of life matters for our children, whether they have medical needs or not. And I know our family is lucky in a lot of ways. We were financially stable going into this, but I cannot imagine any family who could have been hit with the surprise bills we were. No one expects a birth injury. No one expects a disabled child, and you're not set up to pay for it. We had our student loans paid off. We had saved up for our down payment for our first house. We were as financially stable as we thought we could be when we started having children. And there's no way we could have footed that NICU bill, and no one else can as well. It's not a handout. It's necessary. It's a safety net for those surprises, and we need to take care of each other.
Thank you, Courtney, for sharing your family story.
Sorry,
Please.
one
Go
last
ahead.
thing that I want to touch on. The third piece, similar to Katie, my son just finished kindergarten on Friday. And a lot of people don't know Medicaid also helps with those services at school. So my son, Andrew, receives physical therapy, occupational therapy, and speech therapy at school. Medicaid is a huge source of funding for the schools, for these services that our kids receive. Kids that are severely disabled like my son, and those who maybe just need a little help in reading or speech along the way. It's an efficient way to do it and to use those resources. Families like ours, we don't then have to go to 4 appointments during the week if he's getting those services at school. He's able to go to school safely and get fed his lunch through his G-tube because there's a nurse there, because they have equipment there to do so. So just want to make sure I mention that third piece where Medicaid has now allowed him to go to school.
Thank you very much. Any questions, comments from consumers? Go ahead.
I don't have questions for her. I just want to point out to you, I have prior commitments that I'm going to be missing now. So I'm not going to leave, But just for people to be aware, there may be several of us up here that have other commitments.
We do
Thank
have
you.
a few members that
apologize.
have hard stops coming up that will have to leave. We have a few more folks who are on our list to testify today that we would like to get through. But thank you very much
Thank you.
for your testimony and being here today. Next, I will call up Dr. Lindsay Admon, OBGYN from Michigan Medicine. Thank you, doctor.
Well, that is impactful testimony to follow. Thank you so much, Courtney, for sharing your family's story. My name is Lindsay Admon, and I'm grateful to be here today. I'm an OBGYN and maternal health researcher at the University of Michigan and Michigan Medicine. I'm also a mom of 2 young children and a proud Michigander. I'm here today in collaboration with MSACOG and the Michigan Council for Maternal and Child Health. I was inspired to pursue a career in women's and maternal health as I lost my own mother, a single mom who worked 2 jobs, to breast cancer when I was very young. I myself grew up on Medicaid. As an OBGYN, I see many of the struggles my own mother faced persisting among our patients. Instability in insurance coverage, access to care, and high out-of-pocket